Thank you for the opportunity to present my research. My name is Uzair Jogiat. I'm a third-year general surgery resident at the University of Alberta. Today, I'll be presenting our results from a systematic review and meta-analysis on gastric ischemic conditioning. I have no conflicts of interest to declare. Anastomotic leaks are a major postoperative complication, particularly after esophagectomy, a morbid procedure. The anastomosis is at increased risk due to tension from mobilization of the stomach into the thoracic cavity, as well as lack of serosa and longitudinal muscle on the esophagus and ligation of the major blood supply to the stomach, with only intramural arcade supplying the proximal stomach. Studies have reported that decreased conduit perfusion is associated with anastomotic complications. As a means to address this, in the late 1990s, gastric ischemic conditioning emerged and is defined as the ligation or embolization selectively of the blood supply to the stomach to promote neovascularization. However, despite 2 decades of research on the topic, it still remains controversial, with studies failing to reproduce consistent results on the anastomotic complications. And optimal timing, technique, and duration of ischemic conditioning remains unclear, with no consensus established to this date. Our research objectives were to determine the effect of gastric ischemic conditioning on anastomotic complications. Our primary outcome was the incidence of anastomotic leaks, and our secondary outcomes were conduit ischemia, conduit strictures, and overall survival. We conducted a systematic search of the literature on February 5th, 2020. We included references from previously published reviews and our included studies if they met our inclusion criteria, which was an esophagectomy with gastric conduit, age greater than 18, sample size greater than 5, gastric ischemic conditioning performed by any method, and English paper studies. Our exclusion criteria was conference abstracts, duplicates, case reports, and studies utilizing the same study population. And abstracts were reviewed by 1 author, and full texts were reviewed by 2 authors, and any disagreements were resolved by consensus. We extracted data on study characteristics, including the author, year of publication, study design, the N value for ischemic conditioning, and controls. Our baseline patient characteristics included sex, age, comorbidities, performance status, as well as GIC characteristics were the technique, so angiographic or laparoscopic ligation, the number of arteries selected, and the timing of ischemic conditioning. And then our primary outcome was anastomotic leaks, and our secondary outcome was conduit ischemia, anastomotic strictures, and overall survival. Estimated effects were measured with a Mantel-Hansel fixed effects model in RevMan. Heterogeneity was quantified by the I-squared statistic, and significant p-values were defined as less than 0.05. In total, we identified 23 studies that met the inclusion criteria for our study. 2,203 patients were included in the study. About 50% of those underwent gastric ischemic conditioning. Mean time to surgery from GIC was approximately 28 days, plus or minus 37.3. Laparoscopic ischemic conditioning was much more common than angiographic. More patients underwent GIC of 2 or more vessels compared to single vessel GIC. And when oncologic data was available, the majority of patients had adenocarcinoma of the esophagus. Regarding anastomotic leaks, we reported a significant decreased odds in anastomotic leaks for gastric ischemic conditioning compared to esophagectomy alone, with an odds ratio of 0.67, low heterogeneity, and a p-value of 0.03. Regarding anastomotic strictures, we also noted a significant decreased odds in stricture formation for gastric ischemic conditioning compared to esophagectomy alone, with an odds ratio of 0.48, moderate heterogeneity, and a p-value of 0.05. There was no difference in conduit ischemia between gastric ischemic conditioning compared to esophagectomy alone, and there was no difference in overall survival. Unfortunately, there was no data on, no comparative studies on laparoscopic gastric ischemic conditioning compared to angiography. But we did compare outcomes by pooled proportions for these, just to examine the trends. Comparing the two, there were no major differences in mortality, leaks, ischemia, and strictures identified. However, we do have to recognize that there's a considerable difference in sample size amongst the 2 techniques. In a similar fashion, we compared duration of GIC with duration of less than 7 days to esophagectomy associated with a higher rate of anastomotic leaks compared to when ischemic conditioning was performed for greater than 7 days. And lastly, looking at the number of vessels, for less than 2 vessels ligated, there was a higher rate of anastomotic leaks, but decreased stricture formation compared to when greater than 2 vessels were selected. In conclusion, gastric ischemic conditioning was associated with a significant decreased odds of anastomotic strictures and anastomotic leaks. However, there's no difference in overall survival or conduit ischemia. There were limited studies on the technique, the timing of ischemic conditioning, and the duration of gastric ischemic conditioning with no comparative data. And so further research should be directed in this area. The utility of gastric ischemic conditioning in different patient populations also needs to be determined. For example, there was no data on obese patients undergoing gastric ischemic conditioning, and laparoscopic GIC in such patients might be more complicated. And identification of high-risk patients who may benefit most from this procedure is essential. Oftentimes, these patients are undergoing esophagectomy for esophageal cancer with curative intent therapy, and any complication of GIC, either laparoscopic or angiographic, could compromise their oncologic therapy. Therefore, it's important to identify the ideal patient population who may benefit from this procedure, particularly those at increased risk for anastomotic leaks. Thank you very much.